Hey guys, welcome back to my channel, The ENT Resident. Today I'll be discussing a topic, another disease in the nose known as rhinosporidiosis. This is a very important topic not only from the perspective of getting it as a short note in your theory exams, but also for your practical exams where this can actually present to you as a differential diagnosis of a nasal mass in the form of a short case. And you would have to know a little bit more about it to be able to answer the Viva questions. So let's get started. What is rhinosporidiosis? Rhinosporidiosis is a chronic granulomatous disease. And this is not a disease that is only limited to the nose, but rather it is a disease of the mucous membrane. Because it not only involves the nose, and it involves a lot of the parts of the body which has a mucous membrane lining. And this is caused by a parasite which is known as Rhinosporidium Seeberi. And this disease was first described by somebody known as Guillermo Seeber in 1900. This disease can not only be seen in the form of a benign disease, but there's also a version which is known as malignant rhinosporidiosis, which is basically when the disease becomes disseminated. So, the disseminated form of the disease with systemic involvement is known as malignant rhinosporidiosis. There's another peculiar thing about this disease that you have to know, that it defies something which is known as Koch's postulates. So, do you remember what are the Koch's four postulates that is given? So, the four postulates of Koch's is that number one is that a microorganism must be found in all cases of the disease and not in healthy individuals, which means that suspected pathogen in the case has to be present in those with the disease, but it should be absent in those individuals who are healthy. Second is the microorganism can be isolated from the diseased individual and grown in pure culture. Third is when this cultured microorganism is introduced into a healthy individual, that should cause the disease. And lastly, the microorganism which is re-isolated from the experimental host and found to be identical to that of the original microorganism. So these are the four Koch's postulates that have been identified, which basically says that these have to be fulfilled so as to establish that a specific microorganism is causing a specific disease. Now, Rhinosporidium seeberi defies this Koch's postulate in two perspectives. One is the fact that it cannot be cultured. Rhinosporidium seeberi has been seen to be not cultured, and this organism cannot be transferred from a human host to a animal host. So it is defying two of Koch's postulates, which is very important to know. There is another disease which defies Koch's postulates, and that is leprosy, Mycobacterium leprae. Now let's move on to what is the epidemiology of the disease. Now this disease has been seen to be seen in India, more commonly in the southern states like Tamil Nadu, Kerala, MP, Puducherry, and Andhra Pradesh. And this reminds me, can you name a disease which is more common in the northern states? I've already taught about this disease in a couple of videos back, and this disease is known as rhinoscleroma. So, rhinoscleroma is very common in northern India, and rhinosporidiosis is very common in southern India. Other than India, this disease has also been seen to be in Sri Lanka, Pakistan, Africa, South America, North America, Europe, and Canada. Next, let's discuss what is the etiology of the disease. I already told you the etiology of the disease is caused by an organism which is known as Rhinosporidium seeberi. Earlier, this organism was thought to be a fungus, but later it was demonstrated that this organism is actually not a fungus, but rather belongs to a group of aquatic protestant parasite. So now this parasite has been actually included in a new class which is known as Mesomycete along with other organisms which cause similar infections in amphibians and fish. So When your examiner asks you what is Rhinosporidium seeberi, do not mention that it is a fungus because that was the previous theory that was given. Now it has been demonstrated to be an aquatic protestant parasite instead, which belongs to a class known as Mesomycetizoa. Next, let's discuss about the life cycle of this parasite. Now, this life cycle of the parasite, there are three stages to it. First is the trophic stage, then there is development of sporangium, and lastly, there is production of endospores. So, first, let's discuss about the trophic stage. Now, in trophic stage, the organism is known as the trophocyte. This trophocyte, as you can see in the image over here, it is oval or rounded. It is about 6 to 8 micrometer in size. It has a very clear cytoplasm. It has a vesicular nucleus with a nucleolus. And this trophocyte starts increasing in size slowly, and it starts to divide its cytoplasm and nucleus, and hence it leads to development of small endospores within it. Now, as the small endospores start getting formed with multiple divisions, now these trophocytes are getting filled with small endospores. Now, from here, we need on to the next stage, which is the development of sporangium. Now, when a trophocyte has now matured up, a mature trophocyte will now develop into a sporangium. Now, the sporangium is about 200 to 250 micrometer in diameter, and this contains about 12,000 to 16,000 endospores. And this structure, as you can see, the sporangium has a very different structure compared to the trophocyte. The sporangium has two layers, and this forms a very thick wall. And this thick wall is formed by an outer chitinous layer and an inner cellulose layer. This is what forms a thick wall of the sporangium. Now, within the sporangium, as you can see, it is filled with about 12,000 to 16,000 endospores, and these endospores start maturing with formation of their own chitinous wall. Now, once the sporangium is filled with thousands of endospores, it starts developing a germinal pore, and it gets ready to burst out and liberate all these endospores out into the environment. So that leads us to the next stage, which is known as the production of endospores. Now that the sporangium is filled with a lot of endospores, it develops a very high internal pressure. It gets ready to burst through its germinal spore. And then it ruptures from its germinal pore and it releases all the endospores into the surrounding tissue. However, sometimes the internal pressure may not be as high. In that case, the spores start getting liberated by one and without breaking the wall. And after the liberation of the spores, now again the life cycle repeats, and each endospore leads the life of life as a trophic stage, as a trophocyte. So this is how the life cycle of Rhinosporidium goes on. And these endospores, after they have been released, they are carried by lymphatic channels to the bloodstream, and then it causes the disseminated form of the disease. So this is about the life cycle of Rhinosporidium. It has three stages: trophic stage, the development of sporangium, and the bursting of sporangium to release the endospores into the surrounding tissue, and hence it is carried by lymphatic channels to the bloodstream and causes the disease. Now, let's talk about what is the mode of transmission for this disease. The waterborne route has been found to be the most commonest route and most commonest mode of transmission of rhinosporidiosis. It has been seen very commonly in farmers and country dwellers and was thought to be due to bathing in infected ponds. This is very, very important. Sometimes you're given a hypothetical case where it is described to you that the person got this disease after taking a bath in the pond water, and that should be this taking a bath in pond water should be an indication towards rhinosporidiosis, because this is a very common mode of transmission. Because in infected pond water where they bathe animals like cattle and horse, that's how you may end up getting rhinosporidiosis. These spores get deposited in any traumatized part of the nasal cavity or any other areas, and then it continues its life cycle over there. Other than waterborne, there are two other modes as well. One is droplet infection by cattle dung dust, and third is contact transmission by contaminated fingernails. This can be responsible for cutaneous lesions of the disease. Now, next move on to pathology of the disease. What do you see in the histopathology of this disease? I've just described the life cycle to you, how the sporangium forms in the second stage, and the sporangium is filled with multiple endospores and it gets ready to burst through its germinal pore. And that's what we'll actually end up seeing. So, in pathology, we'll see a lot of bleeding polyps, and the structure of the histopathological structure inside will be that there will be a vascular fibromatous structure consisting of sporangium. You can see this is highly vascular. This is a highly vascular fibromatous structure and will consist of sporangium in different stages of their life cycle. You can see this is one sporangium, this is one sporangium. These are all sporangium which are in different stages of their life cycle, and within which the trophocytes will be maturing to mature sporangium. And as I've already mentioned, the size of a mature sporangium will be about 200 to 250 micrometer in diameter, and it will contain numerous pores which are all ready to burst. And the sporangium will also have a thick chitinous wall. You can see over here, this wall is so thick. It'll have a thick chitinous wall with an apical pore ready to burst. So you can see in the image over here, this is a mature sporangium filled with a lot of endospores inside it, ready to burst. So these are the histopathological findings, and this will be very important for you to understand because in your practical exams, you also have your histopathological slides. So this can be a slide that can be given to you, and you have to identify the disease. In that case, if you see a structure like this with a thick wall and filled with multiple dot-like structures, those are all endospores, and you see multiple of them throughout the slide, you can very surely say that this is a case of rhinosporidiosis. Next, let's move on to how do you classify the disease? I've mentioned in the beginning that this disease can also take a malignant form. When I say malignant, I don't mean cancerous, but rather a disease which has disseminated throughout the body and it leads to systemic involvement. So, you can classify rhinosporidiosis into benign and malignant. Benign is when it is very isolated to a certain specific area. So, the most common site is obviously the nose. 78% cases have only nasal manifestations, and 16% you see nasal as well as nasopharyngeal. So that is 16%. Sorry, and nasopharyngeal is 16%, whereas mixed, which is nasal and nasopharyngeal, is seen in 6%. And other weird, bizarre areas of involvement could be the conjunctiva and the tarsal areas. Next is the malignant sporidiosis, which is basically a disseminated form of the disease. And in this disease, what is usually seen is the pH of the nasal cavity remains same throughout the year, predisposing to the infection. Because in normal people, the nasal pH is usually 5.5 to 6.5, except during the humid monsoons when it becomes a little alkaline around 7.1. In rhinosporidiosis, the pH remains same throughout the year, hence it predisposes to infection. And the histamine content of rhinosporidiosis is elevated, which favors the growth of the tissue and blood vessels, supplying it to remain more dilated. So, this is the classification of rhinosporidiosis into benign and malignant. Benign being more specific and limited to a certain area, out of which the most common area to be involved is the nose. And second is malignant, which is a more disseminated form of the disease with systemic involvement. Next, we move on to what do you see? What are the clinical features? What are the symptoms and signs of the patient? So, first of all, this disease is very common in between 20 to 40 years of age, and it definitely has a male preponderance. If you remember previously, I have told you rhinoscleroma is a disease which has a slight female preponderance. So, rhinosporidiosis is a disease which has a male preponderance of 4 is to 1. The common sites involved are nose and nasopharynx. This is the most common. And the other sites could be lip, palate, conjunctiva, epiglottis, larynx, trachea, bronchi, skin, vulva, and even vagina. Now, what are the symptoms of this disease? The patient comes to you with a nasal obstruction due to the developing mass inside the nose. They can also complain of nasal discharge, and this nasal discharge can also often be blood tinged. Patient can even come to you with profuse epistaxis, this can also be the only presenting complaint, and only on examination of the nose on anterior rhinoscopy or endoscopy that you notice that there is a mass inside the nose. Patient can also complain of post-nasal drip, hypoosmia, and sneezing. So these are all about the symptoms of the disease. Now let's discuss what do you find in the patient once you examine. So when you perform an examination of the patient, you will see, if you see in the image over here, you will see a pedunculated pinkish nasal mass. Not just that, it has a granular surface which is studded with a lot of yellowish white spores. And this gives it a specific appearance which is known as the strawberry appearance. And this is the description of the nasal mass that a patient with rhinosporidiosis comes to you with. As you can see, this is a pinkish pedunculated nasal mass, and it seems to be studded with white sporangium, giving it a very granular appearance. This is known as the strawberry appearance. And in the nose, the most common area that is involved is usually the septum and the turbinates. And even within the turbinates, the most common turbinates to be involved are the inferior turbinates and the middle turbinates. And there is one significant important factor over here to know that this disease usually does not cross the mucocutaneous junction of the nose. It remains limited to only the mucous membrane. And other than the mass, you will see that the nasal mucosa is also hyperemic, edematous, and it's covered with a lot of secretions. And this mass is very friable. It is a very friable mass, and it will bleed very easily on touch. And this mass can involve not only the nasal cavity, it can also extend to the nasopharynx and may hang behind the soft palate. In the second image over here, you can see that there is actually multiple sites of involvement. You can see there is a nasal involvement. There is also involvement of the conjunctiva, and there is also involvement of the tongue. This shows the multiple sites of involvement of the disease, and this is not just a disease of the nose. It can involve any area with a mucous membrane. So this was about what you see when you examine the patient. Now let's move on to, you have examined the patient, you have come to a diagnosis that this could possibly be a case of rhinosporidiosis. Now, what are the investigations that you'll perform in this case? First of all, you do all your routine investigations, your blood count and etc. You do an x-ray of the paranasal sinuses. You do a diagnostic nasal endoscopy, and this will actually help you in locating the site of attachment of the nasal mass. A biopsy will be diagnostic of the disease, where you will see the histopathological features that I have described to you previously. That will be helping you in clenching the diagnosis. And then there are some staining procedures that can be done to study the parasite. And out of all the stains over here, the most common, the best one is the Hotchkiss-Macnon stain. It is the best stain for studying the parasite. There are some other stains as well if you want to study the parasite, like Romanowski stain, bromophenol blue, Sudan black, Bismarck brown gap, and methyl green. They all have their specific reasons why you use it, but that is not as important for us to know. Important for us to know is that you should definitely perform a diagnostic nasal endoscopy to see the site of attachment, and biopsy will help you in clenching the diagnosis. And a CT scan, not just an X-ray PNS, but a CT scan of the nose and paranasal sinus will also help you in understanding how much involvement has happened in this case. Now, let's move on to how will we treat the disease. So first of all, the main treatment over here is surgical excision of the disease. You have to completely excise the nasal mass or whatever mass that you are seeing with a diathermy knife, and you have to cauterize the base of it so as to reduce the chances of recurrence of the disease. And if the nasal mass has extended up to the lacrimal sac, only the nasal mass is to be removed. The stump in the nasolacrimal duct will fall out by itself within 2 days. So you have to ignore that part. You only remove the nasal mass in that case. And laser excision is also one of the ways to do this. So this is the primary mode of treatment over here. You have to perform surgical excision of the mass. Next, there is another medicine that is used, which is dapsone. Now, dapsone, the importance of dapsone over here is that it inhibits the formation of folic acid. Now, as it inhibits the formation of folic acid, it leads to arresting of the sporangia maturation. And that's how it helps in treating the disease. Also, it also promotes fibrosis of the surrounding tissue. So, this dapsone is only used when there is a case of systemic or malignant rhinosporidiosis. And the dose over here is 100 mg once daily for about a year. But the role of dapsone in rhinosporidiosis is very controversial, as it has been seen that it does not penetrate into the chitinous layer of the spore. So these are the two treatment options for rhinosporidiosis, the major treatment option being surgical excision of the disease of the mass. Last of all, let's talk about the recurrence of the disease. Even after complete removal, it has been seen to have a high chance of recurrence, and that's because sometimes the disease may remain in the submucosal plane. To prevent any recurrence, we use cautery so as to destroy all the disease in the patient. So that's all about rhinosporidiosis. If you have any more questions, you can get back to me in the comment section and I'll answer your questions. Thank you.